Okay, you can get going when you're ready.
Great, thank you. Good evening, everyone, and welcome to the fifth session from the Masterclass series being brought to you by AO North America's Hand Education Committee. My name is Jai Mudgal, and I'm delighted to welcome you all here. I hope you are being safe with this new variant of the Omicron. And we will continue doing what we are doing, providing high-quality education. And I can't think of a better person to provide us education with about the scaphoid than my old friend, Amit Gupta. I will let Kevin Malone, who's tonight's session moderator, take over at this point, and he will introduce the rest of the crew to you. So thanks for joining us, and Kevin, all yours.
Thanks very much, Dr. Mudgal. Thank you for joining us tonight for our fifth in a series of 6 sessions on our master classes. And tonight is a very special event with Dr. Gupta lecturing us on scaphoid fractures. And as evidenced by his reputation and how interested so many people are to listen to what he has to say, we have over 700 registrants tonight for this program. I'm Kevin Malone from Cleveland, Ohio. I'm the moderator for tonight's session. Dr. Rizzo and Dr. Shoji will be participating in the Q&A session. So if you have questions throughout this seminar, please type them in the Q&A section through Zoom, and we will attempt to respond to those either in writing through the Q&A or good questions we will pose to Dr. Gupta and answer live. Here are the disclosures for those involved in tonight's presentation. Here's our agenda. So we'll very quickly move to Dr. Gupta. He's going to use cases throughout his presentation, so we won't have a formal case presentation session at the end, but we will have some time to discuss questions and answers. There are CMEs that can be claimed, but you will not receive credit for them or will not receive a notification for credit until the series has completed. So our last session is in 2 weeks, and at the conclusion of that session, you will be provided a link to claim your CME credits for the entire series. The AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. The AO does not endorse nor promote the use of any product or service of commercial entities. Equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience. A little bit of housekeeping for, as all of our sessions are, Zoom etiquette. All of your microphones have been muted and your videos have been turned off. So please use the Q&A link on the Zoom window there for your questions. Don't use the chat box because that's for our faculty to communicate with each other throughout. The objectives for this session tonight are that at the end of this series, you will be able to identify the radiographic indications for surgical procedures being discussed. You'll be able to identify and understand clinical criteria required for the indication of the specific procedure. You should be able to define the appropriate surgical anatomy and surgical steps in the execution of this procedure. You should be able to recognize the possible pitfalls and develop strategies to avoid them and methodology to deal with them should they arise. And we'll be able to review the pertinent literature regarding the procedures being discussed and its outcomes. As mentioned, tonight is the 5th in our series of 6 sessions. Our ultimate session will be 2 weeks from this evening with Dr. Hastings discussing hemihamate arthroplasty of the proximal interphalangeal joint. All of these videos or all of these talks are available through the AO North America YouTube channel, and they will be uploaded roughly 24 hours after the conclusion of the seminar tonight, and links will be provided to you to access that session so that you can review it again later. The AO North America Hand Education Committee also has a podcast that we have started. There's one episode online, which is an interview with Dr. Jesse Jupiter, and the link is listed here, and you can download this podcast through any of the services that you typically use. Additional interviews are anticipated. So without further ado, I will turn this session over to Dr. Gupta. Thank you very much.
Thank you. Thanks, Kevin. Appreciate your introduction, and thank you to AO North America Hand Education Committee and Dr. Mudgal for inviting me for this and giving me this honor for the masterclass. So start sharing that. So the topic today is fractures of the scaphoid and non-unions of the scaphoid. I'll present to you my experience for the last 35 years, all my cases here, and I will do an intense review of the literature on the scaphoid fractures and non-unions. Nick Barton said that we may think that we know all we need to know about fractures of the scaphoid. The reverse is true. Most of what we have been taught and we therefore believe we know is unproven, and much of it is actually untrue. Many questions about diagnosis and management remains unanswered. He said that in 1989. Things have changed a lot, and a lot of work has been done in the scaphoid fractures and non-unions, and we obviously have increased in our knowledge. What I'll do is I'll answer questions about scaphoid fractures and non-unions with evidence, and we'll tell a clinical story to outline the answers to those questions. So why do we want to do this? Why do we want to treat fractures of the scaphoid? Well, if we don't treat the fracture of the scaphoid, they invariably progress to non-union, and non-union could lead to arthritis, which is scaphoid non-union advanced collapse. And so we want to prevent this outcome or bad outcome, and we want to treat the fracture of the scaphoid to the point where we can get a union and better outcome. So let's start with the index case. Anytime you see this red background, it will be our index case. So our index case is 16-year-old patient who fell into an outstretched hand while playing soccer. Now, the patient presents with the emergency department with pain and swelling in the right wrist. It's a pretty familiar presentation. There's swelling over the snub box and intense tenderness over the dorsal of the wrist and over the scaphoid tubercle. In the ER, he has some radiographs taken, and we'll show you those radiographs. So you see a PA view and a lateral view. PA view shows that there is perhaps a slight widening of the scapholunate gap, and on the lateral view, slight dorsiflexion of the lunate. I don't see very much in the way of fractures in the scaphoid. And again, oblique view is shown here. So the patient was splinted and asked to make an appointment with the hand office. For some reason, he comes to the office 3 weeks after sustaining the injury. And he complains at that time of pain and swelling in the snuff box, tenderness over the scaphoid tubercle and the snuff box, and decrease in the range of motion. That time at 3 weeks, his x-rays are like this. As you can see, again, some widening of the scapholunate gap here. The scaphoid appears flexed with an end-on view of the distal pole, signet ring sign. There's significant DZ deformity of the lunate. And if you look at the lateral view on the scaphoid, you can almost visualize something going on right about here. I'll do that. So right about this area, something going on right about here. So you see all these things. So diagnosis, depending on physical exam, scaphoid series, that's PA, lateral, ulnar deviated view, and oblique, and then special studies, CT scan, displacement, combination, fracture geometry. MRI will show you contusion, microtrabecular fracture, and occult fracture when the plain films are normal. So in the diagnosis, we come to the Duckworth criteria. Andrew Duckworth from the University of Edinburgh wrote an article in 2012, and this was published in the Journal of Trauma. And he identified, they looked at 260 scaphoid fractures, and they picked out 4 factors: snuff box tenderness on ulnar deviation within 72 hours, scaphoid tubercle tenderness at 2 weeks, patient being male, and a sports injury. Now, they found that if all 4 were positive, the risk of a scaphoid fracture was 91%. That's very relevant, very good paper. So let's look at our patient. So the clinical criteria, Duckworth has snuff box tenderness on ulnar deviation at 3 days, scaphoid tubercle tenderness at 2 weeks, male, and sports injury. All 4 criteria positive, 91% risk of scaphoid fractures. Our index case had 4 of 4 criteria. So we have to have a very high index of suspicion, and then we can go on to doing different investigations. So the radiographs that we normally take in scaphoid fractures are PA nullar deviation, a semi-pronated oblique view annular deviation, lateral neutral, and clenched fist supinated view. So PA with ulnar deviation, lateral, semi-pronated oblique, and clenched fist supinated view. What about MRI? Well, MRI will show you when the X-rays are negative, MRI show you contusions and edema in the scaphoid if there is injury. Not necessarily that there is a fracture, but there is obviously an injury to the scaphoid. There may be a microtrabecular fracture, etc. So what is the role of the MRI? Well, there's a statistical problem. The prevalence of true fracture among suspected fractures is low. This greatly reduces the probability that a positive test will correspond to a true fracture. So false positive are as common as true positives. And secondly, there is no agreed reference standard for a true fracture, so making it hard to compare true positive rates. However, looking at this paper again from Duckworth and David Ring and Margaret McQuinn in JBJS, MRI is the best, despite the possibility of false positives. Let's look at some of the sensitivity and specificity of these tests. MRI, the sensitivity is very high, it's very specific. However, the most important thing is the negative predictive value. If the MRI says there's no fracture, it's 100% reliable. If the MRI says there's a fracture, the positive predictive value is 0.88. Therefore, it's 88% chance that there's a true fracture and 12% there's no fracture. This is based on 22 publications worked out from David Ring's paper. CT scan, again, sensitivity is high, specificity is high. The negative predictive value is high on CT scan based on 8 publications. Bone scan, not much done anymore, but very high sensitivity. Ultrasound, it's dependent on the person doing the ultrasound, but again, fairly high sensitivity. There's a new test called the dual energy CT. And as you can see, conventional CT, if it doesn't show the fracture, MRI will show you bone edema, etc. And the dual energy CT will show you a fracture. And again, here, a conventional CT, the MR T1 and MR stir, and the dual energy CT here showing the fracture. What about CT scan taken along the plane of the scaphoid? Much was written about this, and Sanders wrote about a paper on this, that you should take this CT on the plane of the scaphoid. Well, nowadays, the algorithms are so good that you can take the CT and the plane of the wrist, and then then you can reformat that. And there's a paper about that where they compared the CT scans taken along the axis of the scaphoid and CT scans taken along the axis of the wrist, and there was no difference. There's no significant difference between the two. So they take the CT scans along the axis of the wrist, and then they reformat it to show the scaphoid. Well, our story continues. This patient we've already been through. We've seen the X-rays in the beginning and seen the X-rays at 3 weeks. And so we do a CT scan because we could see a fracture on the lateral view, and CT scan shows there's a humpback deformity, a displaced waist fracture of the scaphoid, and that is why the patient's getting a DZ deformity. And here you can see the DZ deformity, dorsiflexion of the lunate, and the interscaphoid angle is fairly high. So there is a humpback deformity, collapse of the scaphoid in this young patient. So this brings us to classification. What is the classification? Well, you can have tubercle fractures. These heal very well. Distal pole fractures, again, this heals very well too. And then you have these waist fracture, which could be transverse, which could be horizontal oblique, short oblique fractures, or they could be vertical oblique, long oblique fractures, and these are considered more unstable. And then you have the proximal pole fractures. This was classified by Bowman and Campbell in 1962, and they found that transverse fracture was the highest, and transverse fracture had the best prognosis because the fractures would be compressed, and the forces would result in displacement of the vertical oblique fractures. Herbert in 1984 classified them into acute fractures, which he considered them stable, which were tubercle fractures or incomplete waist fractures. Unstable fractures, he said all of the others are unstable fractures. Complete waist fractures, transverse waist fracture, which is complete proximal fractures, and fractures associated with transscaphoid perilonic dislocation of the carpus. All of them were he considered unstable. So the take-home message so far is suspect a scaphoid fracture with snub bulk tenderness, even if radiographs are negative after 2 weeks. You probably cannot go wrong with a non-contrast MRI. Even if it's early, you may discover other injuries. And the important win for the patient is actually discovering the fracture, because an immobilized scaphoid fracture is likely to heal, whereas a non-immobilized will probably go into non or delayed union. So what are the preventable causes of scaphoid non-union? Well, number one is failure to recognize the fracture. Either the patient doesn't come to the hospital, doesn't see a doctor, or the doctor doesn't get an x-ray and misses the fracture altogether. Inadequate initial treatment. The patient is not immobilized in a short arm cast or a thumb spiker cast or anything like that. An improper assessment of bone healing. The patient has a fracture, you immobilize the patient at 8 to 12 weeks, you'd say, oh, well, the fracture is healed, you take the cast off. 3 years later, patient has a small injury and comes back and you see that there is a scaphoid non-union. Perhaps the scaphoid never healed. So how can you tell at x-rays at 8 to 12 weeks whether the scaphoid has healed or not? And let's look at them in a little bit detail. Well, failure to diagnose. Every series in the literature has a significant number of patients who do not have early diagnosis. So in Radford's series in 1990 from Cambridge, 54% non-unions did not have adequate initial treatment. In our series in 1999, 65% did not have adequate initial treatment. In Wong and von Schroeder's study in 2011, more than 50% did not have adequate initial treatment. This is our paper from 1999. And this is von Schroeder's paper, which in 2011. And let's look at this in a little detail. 88 cases of scaphoid non-union, in which 57 had medical treatment initial injury, 27 with delayed presentation, 13 which was less than 4 weeks, and 13 more than 4 weeks. And 31 sought no medical advice or treatment, okay? So all in all, if you look at this cases, the patient factors contributing to non-union is 51%. And the physician factors, that means the scaphoid was missed, no scaphoid fracture seen on x-rays, no further investigation done, was 17%. So the third thing is improper assessment of bone healing. Joe Dias, my friend, did a very good study. He took 20 sets of good quality x-rays at 12 weeks and post-injury, and he sent it to 8 of his best friends, 4 orthopedic surgeons, 4 radiologists. He wanted them to tell him whether the fracture had healed, not sure. And 2 months later, he didn't tell them, but he shuffled the x-rays, relabeled them, and sent it to the same people. What he found was not only did the people not agree with each other, they did not agree with themselves. So there is poor inter and intra-observer correlation of bone union. And radiographs at 12 weeks do not provide reliable and reproducible evidence of healing. So take-home message here is the preventable causes of scaphoid non-union are failure to recognize the fracture, inadequate initial treatment, and improper assessment of bone healing. So far we are here. Now, having diagnosed the scaphoid fracture, the next question is, what characteristics of scaphoid fracture point to a bad outcome? Are we able to, from the literature, pick out some bad actors and maybe we know that these will not heal and maybe go ahead and fix them early? Can we do that? And the answer is yes. If we look at this, the poor prognostic indicators that I've found in the literature are these: displaced fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. If you don't get anything out of today's lecture, take this, because this is very important and this is it's strongly supported by literature. So the indications, you can flip it around. Indications for primary ORIF would be displaced fractures and combinated fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. Let's look at each of them in a little detail. Displaced fracture. What are displaced fractures? Well, from early on, from 1975 onwards, it's been clearly shown that more than 1 millimeter of displacement is a bad indicator, it's a bad actor. If you have more displacement, this fracture is way displaced. So this would not heal, and this has to be fixed early. Well, Edlund in 75 had 19% non-union overall. More than 1 millimeter displacement is 92% non-union, and zero displacement is 13% non-union. Graywall, Nina Su, and McDermott in 2013 had 22% non-union in displaced fractures. And these are the papers which show displaced fractures are bad actors. So here you have a displaced fracture, which needs to be reduced and fixed. Another displaced fracture, you can see the gap here, quite a bit displaced, more than 5 millimeters, more than 2 millimeters. Now, you need a CT scan to really get the sensitivity up. Plain radiographs may not show it because scaphoid is a curved bone, so you need a good quality CT scan. It increases the sensitivity of displacement by 77%. Also, it increases the accuracy of diagnosis. Now, truly undisplaced fractures, you can make your criteria very strict. Lack of any displacement. And if you do a CT scan, the scaphoid unit angle should be less than 60, capital unit angle and radial unit angle should be less than 15, the sagittal interscaphoid interfracture angle should be less than 30, the coronal interscaphoid angle should be less than 40, and the height ratio should be pretty normal, and there should be absence of comminution. So if you do a CT scan, you have in a plain X-ray, you have a fairly non-displaced, completely non-displaced fracture here, but the sagittal and the coronal interscaphoid angles are within normal limits like I showed you. Now, if you look at Joe Dias and Singh's paper, the odds of non-union are 17 times when displaced fracture treated in a cast compared to surgery. And they looked at this meta-analysis of 7 studies, and they said odds ratio, displaced fracture have 4 times higher risk of non-union. So there you have it in the literature. What about comminuted fractures? They are unstable. It takes a large amount of force to produce a comminuted scaphoid fracture. So here's a comminuted scaphoid fracture. We go on to fix it early with a screw from the volar side, and patient goes on to heal very, very nicely. So here's a comminuted fracture. This is reduced and fixed with a screw from the proximal side, and this goes on to heal. There's a nice paper on use of CT to predict union and look at all these bad actors. So they looked at humpback deformity. When you have humpback early on, like in our patient, there's 7 times chances of not healing. If you have a translation, that is displacement, there's 3.5 times chances of not healing. Combination, 2.5 times more chances of not healing. Now, in each of these series, the figures, numbers vary, but the message is that these are the bad actors that I was talking about. In the same paper from Ruby Graywall, Nina Su, and John McDermott, if you look at standard scaphoid, non-displaced scaphoid, time to union with a cast, non-operative treatment is 48 days. When you add comminution, it adds 29 days. You add translation or displacement, it adds another 45 days. You add sclerosis of the ends, that's another 102 days. And if you add proximal pole fractures, that's 46 days plus 48 days. So as you can see, these are all bad actors. What about unstable fractures? Fractures which are different patterns, which have an unstable pattern. And this has been shown clearly from in the literature in the past that these are bad actors. And we talked about this. The transverse fractures can compress, whereas the vertical obliques can displace. And also, but you have to, again, keep your criteria very, very strict. Displacement which should be 0 millimeters if it's stable. If it's unstable, it's more than it's displaced fracture, and the presence of any combination, proximal fracture, transscaphoid, pedal, they're all counted as unstable fractures. Again, CT scan increases the sensitivity and increases the specificity of the accuracy of the diagnosis. Now, even completely non-displaced, non-angulated, non-comminuted scaphoid fractures on CT have been found to be unstable if you scope them. If you put a scope in your midcarpal joint and you scope these, you'll see that a third of those so-called unstable fractures are actually unstable. And here's an example. This patient has a fracture which is horizontal oblique, maybe vertical oblique slightly, and here is a vertical oblique fracture. So this patient, you do a CT, you do an arthroscopy of this patient, and here is a scope. We are looking at the radiocarpal view. There's a comminuted segment, and we're separating that out, and then loose bone fragment there. And then if you look inside, if you look at the midcarpal joint, and that's this midcarpal view, look at the scapholunate area there. And then if you go further towards the, that's the widened scapholunate interval along with the scaphoid fracture. And if you go further towards the fracture, and you see that fracture there, and that is unstable, and you can move the fragments around. So these will require early operative management. Then the third point is the third group is the fractures with carpal instability and deformity. So these are clearly unstable. So they're in different towns, but patients who have this humpback deformity, and I showed you in Ruby Graywall and in the Sue's paper that patients with humpback deformity, they are also bad actors there. And so these are quite distinctly, they have to be fixed, they have to reduce nicely, and they have to be fixed with measures which will provide stability. Proximal pole fractures, these are unstable. So these have been shown to be bad actors. Reddick and Raskin showed that retrograde screw fixation in 17 patients, all united 13 weeks. Eastley publication, they looked at 1,147 acute fractures, and 5.8% are proximal, 34% progressed to non-union when treated non-operatively. So there's a proximal pole fracture. These have to be fixed early and fixed properly so that they can heal. So here's a proximal pole fracture fixed with a screw. And again, here I'll show you Eastley's paper. This is Joe Dias and Hari Singh. The relative risk of non-union is 7.5% more when proximal fractures, pole fractures are managed non-operatively compared to distal fractures. So 7.5 times more. And here's a proximal pole fracture, which has some avascular changes on the MRI. And then these are fixed primarily, and this goes on to revascularize with full restoration of function. Here's a 19-year-old soccer player, hit on the wrist by a soccer ball, wrist was hyperextended, there was pain and swelling in the snub box, tenderness in the snub box, and scaphoid tubercle. So here's a pretty undisplaced type of fracture if you look at it, but proximal pole, 20% of the scaphoid. Now, when you go on to fix it, now look at this. It shows you that it's unstable. As soon as you put in a guide pin in there, it's unstable. And this is a 14-gauge angiocath, and I love to use this, and I'll tell you all about this. So you put a 14-gauge angiocath, so you can use this as a guide for putting your guide wire in there, and also it is a tissue protector and also prevents your guide wire from bending. And I use this for volar or dorsal approaches everywhere. And here we are just putting the guide wire in, and then the screw goes into the center. And then this goes on to heal pretty nicely without problems. So take-home messages are characteristics of scaphoid fractures that point to a bad outcome: a displaced and combinator fracture, unstable fractures, fractures with carpal instability and deformity, and proximal pole fracture. Improper early treatment, improper assessment of bone healing can lead to scaphoid non-union. So scaphoid waist fracture algorithm, well, unstable displaced humpback deformity, yes, go on to surgery. If no, non-displaced, no humpback, stable fractures, casting for 4 to 6 weeks, then I do a CT and begin motion. So there were some papers coming out which showed that percutaneous screws, time to union is 6-7 weeks, cast immobilization, time to union is 11 weeks. There was no difference in the grip strength, in range of motion, patient satisfaction. This is from Dr. Bond and Dr. Shin. And very encouraging. And again, randomized studies show percutaneous screw fixation. The time to union was shorter, 9.2 weeks. Cast immobilization was at 14 weeks. No difference in the grip or pinch strength. But then recently, a huge study came out from Britain. It's called the SWIFT study, Surgery versus Cast Immobilization for Adults with Biocortical Fractures of the Scaphoid Waist. This was a lot of authors, but main author was my friend Joe Dias. It is a pragmatic, multi-center, open-label, randomized superiority trial. It's very rarely that in orthopedics and hand surgery, we pick up papers from the Lancet. Well, they had 439 patients. 205 was in the cast and 203 in the surgery. So there's a very good comparative. And they did a PRWE at 52 weeks, and surgery had more complications. There was no difference in the union rate. Reoperations and complications more in the surgery group. They did a CT scan at 52 weeks, and they saw screw penetration in a large portion of these scaphoid fixations. There was no difference in return to work in these two groups. There was no significant difference between cast and surgery in non-displaced scaphoid fractures, less than 2 millimeters in this group, in this study. So according to them, 73 scaphoids you need to fix 73 scaphoids surgically to avoid one non-union. And the 95% confidence interval is 24 to 100. So adult patients with scaphoid waist fractures displaced by 2 millimeters or less should have initial cast immobilization, and any suspected non-unions or delayed unions, you can pick those out, should be confirmed and immediately fixed with surgery. This treatment strategy will help to avoid the risk of surgery and mostly limit the use of surgery to fixing fractures that fail to unite. So what kind of cast would you use? Well, would you use a scaphoid cast or a Colles cast? Well, there was a nice study again from Joe Dias and Nigel Clay and Nick Barton, and there was no difference between the scaphoid cast and the Colles cast, but the Colles cast is much more comfortable for the patient. Now, how do we treat them? So you put in a cast, you then CT scan at 4 weeks, or in my case, we do it at 6 weeks. So this is a study from Nottingham in which they put the patient in the cast of non-displaced fractures, and they CT scan them at 4 weeks. What would you see? So you see union, partial union, you start range of motion. If you have 50% union, you can start range of motion. And if it's about to heal, then you can give 4 more weeks, or you can go on to surgery depending on the what the CT scan shows. 25 of 26 united at 4 weeks of immobilization. So here's a patient who is 25 years old, motorcycle accident. The patient spent 6 weeks in a Colles cast, CT scan at 6 weeks. So there's a non-displaced fracture, as you can see. Non-displaced fracture in the initial period, CT scan at 6 weeks, completely healed. And even if it's 50% healed, I would let the patient go. Same unit, Nottingham, from Tim Davis's unit, displaced scaphoid waist fracture, use of 4-week CT to predict likelihood of union. Shows that it can get partial union, full union, like partial 50% union, and that's pretty good. That's good enough, actually. Or it'll show you something bad, like a fracture gap. So if this happens, then you take the patient to the OR and fix it. Or it'll show you sclerosis. Again, this is bad. You have to fix it. Or you'll see what George Perkins used to call cystic dieback. When this happens, you need to fix it. So this is our paper with Michael Sincere and others, which showed that we can do this fixation with a percutaneous or a mini open from the dorsal side or from the palmar side, depending on where the fracture is. And here we're doing it with a mini open fixation. Now, we used to do this, put the guide wire in, but I changed this to putting a 14-gauge angiocath. I take the plastic off. Don't use the modern ones with the spring, just the old ones, and take the plastic off and drill it into the scaphoid. This will show you exactly where your guide wire is going to go. And you can then put the guide wire. It'll act as a tissue protector. It'll act as a guide, and also it'll prevent any bending of this wire as you straighten the wrist. So you then put the screw in, and here you see if you don't use the 14 gauge angiocath, the guide wire will bend, whereas if you use the angiocath, the guide wire does not bend if you extend and flex the wrist. So multiple fractures which are delayed healing at 6 weeks, 8 weeks, you see this CT scan and it's not healing, then you just go ahead and fix it, and you don't have to graft it, it'll heal fine. If there's cystic dieback in certain instances, you can graft them, or sometimes you want to see that they're unstable, then you can do dorsal percutaneous arthroscopic fixation, and you reduce, if the fracture is displaced, you can reduce it, put an arthroscope in the mid-carpal joint, you see the reduction, and you can put your pins and you put your screw, and it's nice to reduce and fixed. Again, displaced fracture fixed. If you have a cystic dieback like this, you can look in the mid-carpal joint and you drill this area after your guide pin, and then you can use a Jamshidi needle, take some bone graft from the distal radius, and you can pack this bone graft in. And here we have the bone graft, and you can see some of it is leaked out here, and you can put a screw across here, and that one goes on to heal very nicely. So our index case, we carry on. We saw this patient at 3 weeks. We diagnosed it as a waist fracture with humpback deformity. And here you see the humpback deformity there with the DZ deformity. So here we open it from the volar side because we need to reconstruct the shape and geometry of the scaphoid. We put these joysticks in the proximal pole and distal pole. We open up the scaphoid. This guy's 17. He wanted to join the military. So he didn't want any screws or anything in his scaphoid. And so we open it up, and the gap needs to be filled. You can fill that with Cancellous, Cancellous graft. We took some graft from the crest, we put it in, and we put 3 K wires to stabilize it. The fracture was stable with the graft. We just added the 3 K wires to prevent rotation or instability. And we wanted to take the K wires out. So we took the K wires out, and he got excellent result, full function, and he went to the military. So instability, another example, 20-year-old patient, Division I soccer player, kicked in the right wrist for 3 weeks prior to being seen in the office. Initial x-rays will show you patient did not want to have surgery in the beginning. So treated in a cast initially. CT scans at 6 weeks. So there's a initial x-rays, vertical oblique fracture. And now you see the gapping at 6 weeks and a cystic dieback. So this is the time when you say, well, this is not going to heal. So we go ahead and fix this with a screw fixation, and there's no graft necessary now. It just compress it and it stabilize it, and it'll go on to heal. And this goes on to heal and full range of motion. Patient is a 50-year-old, motor vehicle accident, right wrist pain, seen in the immediate care center. X-rays, no fracture, splinted and seen in the office. X-rays at that time in the office showed a scaphoid fracture. Patient wanted to try non-op, casted, and goes on to December when you have a CT scan, and there you see initial fractures is displacement, 5 millimeter displacement. So this is a bad actor, and this doesn't go on to heal. So patient has a fixation. This patient is 20-year-old, injured wrist 3 months prior, rock climbing. So late presentation, pain and limitation of movement of the wrist. And as you can see, the scaphoid is deformed. And the scaphoid is deformed because it's got a humpback in both planes, in the sagittal and coronal planes. And as you can see, there's a huge DZ deformity, and the scaphoid is bent quite a bit. And as you see into scaphoid angles of over 90 degrees. So bone graft, in this case, a Cancellous bone graft, and screw fixation. 21-year-old patient injured while playing football, pain and swelling in the snub box, tenderness in the snub box and scaphoid tubercle. All of the criteria are present. And here you see the non-displaced fracture of the proximal pole. And here is fixed with a stabilized with the screw fixation and goes on to heal very nicely. Full range of motion. 63-year-old patient, history of fall, mid-waist fracture, displaced. This fixed with a distal screw fixation. Again, 14 gauge angiocath. You get a center. You can push the trapezium out of the way with this and get a better positioning. And once you get the positioning, then you put the guide wire. You know where it's going to go in APN lateral planes. And putting the screw in, and it's fixed. Now, there's a cystic dieback, delayed union. So 18-year-old patient fell while playing football, displaced fracture, getting a little cystic dieback, but compressed and stabilized, and goes on to heal very nicely. And CT scan showing that it's healed well, full range of motion. So these are the take-home messages that we mentioned, that immediate ORIF are those bad actors that we do. And then if we treat them in a cast, we look out for these gaps, displacements, sclerosis, or cystic diebacks. And once we see them, we can fix them secondarily. Okay. So which side should you put the screw? Well, it depends on where your fracture is. If the fracture is more near the proximal pole, I go from the dorsal side. If the fracture is more near the distal pole, I go from the volar side. And in the waist of the scaphoid, it is dealer's choice, wherever you want to go. And if you want to do an open, then you can go volar roost approach if you want to put a graft in there. So let's skip this for a second. And so what's new in scaphoid fractures? Well, Philippe Leverneau and others have been doing this. They put this a guide with a computer-assisted guide to put a center screw, and this is just to mention what's in the literature now. Next, we go on to Scaphoid Non-Union. So London in 1961 said 95% fresh fractures united with proper initial management. That was a paper on broken scaphoid, case against pessimism. But is that the real number? If you look at the literature, the real number is more like this: 12.3% incidence of non-union in all comers. So these fractures, the ones in the distal pole, tubercle, distal pole, and stable fractures, they'll all heal. These may not heal, proximal pole fractures, and we talked about that. And this is our paper that showed the distal pole fractures. We picked up some fractures of the distal pole which did not heal. And again, I'll just repeat that: the preventable cause of scaphoid non-union, failure to recognize a fracture, inadequate initial treatment, and improper assessment of bone healing. And we went through all that. What about delay in diagnosis? Well, Langloff and Anderson in '88 said that if the delay of diagnosis is less than 4 weeks, the union rate is same as fresh fractures, but the delay in diagnosis more than 4 weeks, the incidence of non-union increases. So improper assessment of bone healing, we talked about this. The intrinsic causes, those are the preventable causes. The intrinsic cause of scaphoid non-union are interruption of blood supply. The study of blood supply of the scaphoid has gone on for a long time. In 1938, Oblique and Halbstein from the University of Iowa, they looked at scaphoids. They took dried scaphoids and they counted the foramina. And they were able to see that lots of foramina in the distal pole, some foramina in the waist, and very few in the proximal pole. Gelban and Menon and Telesnin and Kelly did very good, sophisticated studies of the scaphoid vascularity, and they showed that in the proximal pole, there were these end arteries, and if you had a fracture there, this one won't get much blood supply, whereas in the waist, there's lots of blood supply. The distal pole, there's lots of blood supply. And the beautiful pictures from casting and injected specimens. And recently, Moran from Mayo Clinic has shown this beautiful pictures of the scaphoid with injected CT scans. So this was the early study in '38. Oblique and Halbstein examined almost 300 dried scaphoids at the University of Iowa. 13% had no foramina proximal to the waist. 20% had one foramina proximal to the waist, and 67% had 2 or 3 foramina proximal to the waist. So he said the ones which don't have any foramina, they don't have much blood supply, and the proximal pole fractures may go into problems. But after all these sophisticated studies over the years, we basically come to the same conclusion So you have these beautiful computer-assisted studies and Oblitz and Holstein's study of counting foramina, and it tells you basically the same thing. So the intrinsic causes, we mentioned again, combination displacement, unstable fractures, associated carpal instability, and proximal pole fractures. Same thing. Now in 1984 and 1985, there were these two papers of the same name, The Natural History of Scaphoid Non-Union. One was by Commander Gregory Mack. This was Gelberman. Dr. Gelberman was there. And there's one by Dr. Ruby's unit, and Mark Belsky was with him. So the problem is we all know that there are a whole bunch of people who are walking around with scaphoid non-union who do not have any pain. So these papers were only looking at patients who came to their office with pain. So they should be called natural history of painful scaphoid non-union rather than natural history of scaphoid non-unions, okay? And my friend, Dr. McCabe, wrote a paper criticizing that this is, we don't know the actual numbers of non-unions which are in the world which do not have pain. Be as it may, what these papers showed that something is happening to the wrist as the years go by. As the years go by, 5 to 9 years, 10 to 19 years, 20 years or more, what is happening? The displacement of the fragments of the scaphoid is increasing, more and more displacement. The angles are getting worse. The carpal height is getting worse. So the biomechanics of the wrist is getting worse, and eventually they all get arthritis. So these two papers showed that there's more displacement, there's increased carpal instability, and eventual arthritis leading to snack wrist and this sort of appearance. And from Sweden, Lindström showed that if you have a scaphoid fracture which does not heal, and if you take a bunch of scaphoid fractures which healed and compare them, you get arthritis at 10 years. 9% with united fractures, but 93% arthritis with ununited fractures of the scaphoid. So there's a big difference between union of the fracture of the scaphoid and ununited scaphoid fractures, the incidence of arthritis at 10 years. Now, Åke and Lindström in 1992 looked at some patients. They had a population of 33 patients in one town in Sweden who did not want to have fixation. So they had 33 scaphoid non-unions. And they followed them for 10 to 17 years. And they found that there was 100% incidence of arthritis 10 to 7 years after the diagnosis. Okay. So how do we treat non-unions? Well, in the past, traditionally, it's called the Matty-Roos. Now, what's a Matty-Roos procedure? I think it's a myth because Herman Matty, lived in a different time. He lived in 1930s, and he was in Bern, and he did a different operation. Basically, he scooped out the scaphoid, filled that with Cancellous bone graft, and that was Matty's operation. Whereas Otto Roos lived in Vienna, and he also scooped. The only common thing is they scooped out the scaphoid, and he put this like a cake, the Cancellous graft in between, and this was Roos's procedure. But over the years, lots of papers have come out talking about the Roos grafting, and it has shown very good results, 90%, 100% good and excellent results. But Jeffrey Fisk in '68 showed us that there is carpal instability, and fracture scaphoid has carpal instability. And what happens is the scaphoid fractures can go into malunion, can go into collapse, into and non-union. And he showed that the scaphoid puts a lot of pressure on each of the fragments here, and that's how this interscaphoid angle gets worse. That's how the DZ gets worse. That's how the carpal mechanics gets worse. So that was a beautiful lecture, the Hunterian lecture by Jeffrey Fisk. So he said correction of the flexion deformity of the scaphoid and restoration of the normal scaphoid length reestablishes the normal tension in the palmar radiocarpal ligaments and corrects the pathological rotation of the lunate. So there was Diego Fernandez. Diego Fernandez took this concept and measured the opposite scaphoid and took the measurements in APN lateral films and he reconstructed the geometry and shape of the scaphoid using Cancellous bone graft. And in his first papers, he put in K-wires. So this was in 1984, this paper from Diego Fernandez. So it came to be known, this procedure came to be known as Fisk-Fernandez technique. Opening up from the volar side, reconstructing the geometry of the scaphoid, and fixing with K-wires initially. And subsequently, Cooney and others from Mayo Clinic put in screws. So started putting screws in there for these correction of the deformities. And they had an 81% union rate, open reduction, length restoration. So here's an example from the 1990s with displacement. And what you do is put joists in the proximal and distal pole and open it up. And as you open it up on the volar side, you know how much bone graft you need, and you can take a Cancellous bone graft and you fix that in, and there's a gap. There's the gap that you see with the joystick in the fragments, and you put the you see the gap, and you take a tricortical or a bicortical graft from the crest, and you punch it in, and you reconstruct the geometry of the scaphoid. In the old days, we used to put a Herbert screw and then an anti-rotation K-wire. But now with the new screws, you probably don't have to do that. Here's another example, putting the Herbert screw and fixing it with the grafting. And another example with measuring the opposite side. And here's the gap between the two ends. And you put in the bicortical graft here, and you reduce the lunate and keep it fixed in that position with this K-wire from the radial side. And then you put in the K-wires, and then you put the guide wire, and you put the screw in from the volar side. That reconstructs the shape and geometry of the scaphoid, corrects the DZ deformity. So this is scaphoid waist non-union with humpback deformity treated with structural bone graft, without structural bone graft. So you don't have to put these structural bone graft. You can use Cancellous bone graft, and Mark Cohen and Jesse Jupiter showed that. What you do is you take Cancellous bone graft, put it in a syringe, and compress the syringe. You keep the fluid, the blood that comes out, because that's got lots of good stuff. And then you take a K-wire and push the compressed Cancellous bone graft out, and then you pack that in. So you don't have to do a big Cancellous graft. You can just put Cancellous graft in there, and then you just put a screw in there. So this patient's 18-year-old, fell while playing football, surgery. We did ORIF with Cancellous bone graft from distal radius. So he has displaced fracture, ORIF with Cancellous bone graft from distal radius, and fixation with a screw fixation there. What's new? Well, people have tried to do computer assisted, and you can do these guide wires and these jigs and correct the scaphoid. And Lari Neji from Zurich, Switzerland, he lent me his slides. And for Scaphoid Non-Union like that, you can get an accurate reduction of the scaphoid and correction of the geometry of the scaphoid, grafting and correction of the DZ deformity. There are certain factors which affect this, open reduction, wedge grafting, and fixation. The bad things can happen if the fracture is more than 5 years old, if there's a proximal third non-union, the sclerosis of the proximal fragment, and unsatisfactory reduction of the DZ deformity. So you have to reduce the DZ. Now, let's talk about the dysvascular scaphoid, or people call it avascular necrosis. I like to call it dysvascular scaphoid. The scaphoid is not dead. It's just less blood supply, as you can see on the MRI. The radiological diagnosis is faulty. Dr. Green talked about lack of bleeding at operation. Perlich and Guilford talked about the MRI changes. But avascular fragments can unite. And after union, avascular fragments will revascularize. Dr. Peter Carter was in Dallas, and he used to take allografts of the scaphoid proximal pole and fix it stably, and he got them to heal. So if a dead scaphoid from a Miami bone bank can heal, patient's own dysvascular scaphoid can surely heal if you stabilize it. And here's a proximal pole non-union, very poor vascularity, hardly any bleeding points there. So here's a patient who has on the MRI has avascular changes. And again, on the MRI, has avascular changes. Also, the plain X-ray shows dense sclerotic proximal pole, but you fix them, you stably fix them, compress them, and you don't need to do, and it'll heal, and you get the scaphoid will revascularize. So that brings us to vascularized bone grafts for scaphoid non-unions. Problem, scaphoid non-union with dysvascular changes, or patients have had multiple surgeries in the past. Those are the difficult cases. This case, like patients have displaced non-union with avascular proximal pole like this. These are the cases that I use vascularized bone graft. Scaphoid fracture, certain things common with the femoral neck fracture. It's a tenuous blood supply. It's an intracapsular fracture, so there is no fracture hematoma, because every time if you get a fracture hematoma in a joint, the joint will become stiff, so that there are lysozymes which dissolve the clot. So intracapsular fractures do not form the fracture hematoma, and you need a fracture hematoma for bones to heal. Again, in the scaphoid, there's no true periosteum. There's a fibrous layer of the periosteum. The fracture configurations are similar. We got this vertical oblique type of fractures, and there's high torque at the fracture site. So Malone, Wolf, and Slade did a meta-analysis, and they found that in scaphoid non-unions with avascular changes, vascularized bone graft resulted in 88% union, and non-vascularized bone graft had only 47% union rate, which was significantly different. So when did this all start? It started with Yoshida Hori. Hori took lots of dogs and took these vessels and implanted them into bone, and found that these vessels sprouted, and there was angiogenesis of these vessels. So people then started taking bone with a vascular component and putting them in another bone so that they would get vascular supply. And Braun did the early grafting, and Pesi Chacha in Singapore did early grafting in the mid-80s. But Zeidenberg showed us that you can take the what is now called 1,2-ICSRA, that was Zeidenberg's contribution, 1991. And Sheets, Bishop, and Berger had this beautiful article in 1995 where they showed the vascular anatomy of the distal radius where you can take bone graft from. So Zeidenberg and Angrigiani in 1991 described new source of vascularized bone graft from the distal radius. It was very new at that time. But Sheets, Bishop, and Berger investigated the extraosseous and intraosseous blood supply of the distal radius in great detail and showed the potential of vascularized pedicle bone graft into carpal bones. And this is Zeidenberg's paper from 91, and this is Sheets, Bishop, and Berger's paper from 1995. So there are other sources from distal radius. You can get from the ulnar artery, palmar carpal artery, first dorsal metacarpal artery, anterior interosseous artery, and you can get free iliac crest. You can get the medial femoral condyle, lateral femoral condyle. So let's look at the distal radius, dorsal radius. So you get 1, 2 intercompartmental, between compartments, supraretinacular, or on top of the retinaculum artery. And the second EC, that's inside the extensor compartment branch. So you have 1, 2 ICSRA, second EC branch of 1, 2 ICSRA, 2, 3 intercompartment, 2, 3 ICSRA, second EC branch of 2, 3 ICSRA, fourth extensor compartment. This goes in the extensor compartment, fourth extensor compartment. I'll show you the examples of this. So people have injected dye, and they find that you have a large territory of vascular supply in the bone, deep in the bone. And you can see that in the dorsal side, on the radial side. These are from Zeidenberg's work. So here's a diagram which shows all the vessels. You have the radial artery, you have the ulnar artery, you have the posterior interosseous artery, you have the anterior interosseous artery, and then you have these vessels coming across here. This is the 1, 2 ICSRA, this is the fourth EC, and this is the fifth EC, fifth compartment. So multiple areas you can take vascularized bone graft. You can take this vascular bone graft on this and come across here, clip this vessel, and go on this pedicle, and this could be a long pedicle. So here are some injected specimens. The tendons have been taken out. This is the first dorsal compartment. This is the second dorsal compartment. This is between the first and the second is 1-2 supraretinacular, intercompartmental supraretinacular artery, 1-2 ICSRA. And you see, this is 1-2 ICSRA. It comes off the radial artery, goes back and connects back with the radial artery. Then you have the 2-3 ICSRA. This is the fourth, but this goes in the extensor compartment, ECA, fifth ECA. And here is an injected specimen. Our dissections shows first compartment and second compartment and third compartment here. And you see this is 1-2 ICSRA. And you take bone graft right here. And you have to clip the vessel on this part. And this is the 1-2 ICSRA. And this is the second and all sorts of other vessels coming across here. And this is the 1-2 ICSRA going across here from the radial artery. And you see the origin from the radial artery goes deep to the tendons of the first compartment and goes between the first and the second compartment. And here again is the 2-3 ICSRA. And I think some people take the 2-3 ICSRA. And you can take vessel on the 2-3, or you can take vessel on the fourth. You can take bone from here, then clip the artery here. And then this will give you a long pedicle, and you can go on to the lunate, go on to the, you can even go into the metacarpal with this type of vascularized bone graft. On the palmar side, there's two vessel supply. There's palmar metaphyseal arch, and there is a palmar carpal artery. Let's look at this. On the palmar side, you have the pronator quadratus, you have the radial artery here, ulnar artery here, and you have the palmar metacarpal artery, this part, the radiocarpal artery here, and then you have a palmar metaphyseal artery right here. So this, you can take the pronator quadratus along with it, and I'll show some examples of that too. And here is the palmar carpal artery. From the radial artery, goes on and connects with the anterior interosseous artery. So you can take, so here's the joint. Make sure you don't enter the joint, but you can take bone graft right here. Okay, and then you can, this will reach the scaphoid very easily. And we've taken out the pronator quadratus, and you see the palmar carpal artery, and you see the vessels going into the radius, and you can take bone right here on the ulnar side, or you can take it on the distal ridge. So there are lots of papers on vascularized bone graft, and if you look at the literature, they have shown very good results, 100%, 80%, 91%. There's one outlier, which was 27% non-union. I don't know what happened there. But overall, it's about 80, 90, 100% excellent results. And again, here, previous studies, these are all the studies from on avascular proximal pole of the scaphoid treated with vascular bone graft and fairly good union rates. So here's one clinical example. Displaced non-union, 1-2 ICSRA, and we take grafts. We have to cut the grafts parallel to each other. So don't go with like a wedge, cut them parallel going into the metaphyseal bone and lift them up. So this goes 1-2 ICSRA. This is the pedicle. This is the bone graft. And here we open up the scaphoid, and we open up the scaphoid, hardly any blood vessel here in the proximal part. And this just to show the fellows that it actually is vascularized bone graft. That's another case. So we put in that in between the two as a sandwich, and then we put in the screw there. That this goes onto here. So Steve Moran, Alex Shin, and Alan Bishop and Michael Chang wrote up this in between 94 and 2003, 50 scaphoid non-unions using 1-2 ICSRA. 34 out of 50 united, an average of 5.6 weeks. The risk factors were old age, proximal pole AVN, preoperative humpback deformity, large bone defect. If they used, if the screws were not used, patient was a smoker, female, age of non-union, and previous surgery. In this meta-analysis I told you about, this is Merrill, Wolf, and Slade's vascularized bone graft and scaphoid non-union with AVN, 88% healed. Non-vascularized bone graft, 47% healed. So vascularized bone graft was superior according to this meta-analysis. So here's one example of vascularized bone graft with screw fixation with good results. This is from my friend Dr. Bickel, and this is open from the volar side. You can see the joysticks in the proximal pole, distal pole, and the area of grafting that's required. And this is taking that pronator quadratus, the whole of the pronator quadratus, along with going on to the radial artery. And you can take the vascularized bone graft, large amount of vascularized bone graft there, and it'll recreate the shape and geometry of the scaphoid and fix with one screw. Now you can take, as I mentioned, you can take this part, and lately I've started taking the palmar carpal artery blood vessel, and this was a paper from Hill Hastings and summer camp, and they took bone graft in this area. So here you pull the pronator quadratus down, and you take the vessel here, and you take bone graft on that. And here's an example, a clinical example showing the vascularity, the transverse artery, the palmar radiocarpal artery. And here again, this is the pronator quadratus. This is the joint. This is scaphoid, palmar radiocarpal artery. So here's the needles into the joint, showing that you do not want to go to the joint, and bone graft taken out of here. And you get a sizable amount of bone graft. You can reconstruct the scaphoid and putting screws into that. So this is vascularized bone graft, putting into the volar aspect, reconstructing the shape and geometry of the scaphoid, and the screw put in there like that. And here are examples of that, showing union with CT scan. And here's one case, this 8-month-old history of injury to the wrist, fell off a skateboard, no treatment, fell off the skateboard again in May of 2021, injured the right wrist, presented with non-union of the right scaphoid. Very unstable non-union of the right scaphoid. There's volar vascularized bone graft using palmar carpal artery, and we use 2 screws. So this is a young guy with a non-union, 2 screws, one 2.5, one 3.5 screw, and here's the bone graft taken from the palmar carpal artery. And this goes on to heal with excellent range of motion, going back to skating. 23-year-old patient, pain left wrist for 3 years after trauma, no treatment for 3 years. Initial ORIF, the left scaphoid with bone graft from the radius and screw placement. And here's the screw placement, bone graft taken from here, Alam Mark Garcia Elias. And here's the bone graft. This is non-union. So this is a complex case. So I put a palmar carpal vascularized bone graft and a scaphoid plate, stabilized it, and it went on to heal very nicely with excellent range of motion. This patient had scaphoid fracture. He's a football player on scholarship at the university, scaphoid fracture. Somebody puts this K-wire penetrates, patient gets avascular changes, and also develops an infection with draining sinus. So patient now has a sequestrum in there, as you can see. So lots of strikes, non-union, infection, and avascular necrosis. So a patient was prescribed excisional scaphoid with the 4-corner fusion, but once we cleaned out the infection, 6 weeks of antibiotics, then the patient had vascularized bone graft. We packed the graft in this and cantilevered it. The screw is not in the wrong place. We just fixed it in that position, and this went on to heal with excellent result for him. The other areas are MFC reconstruction, taking the medial femoral condyle, and you can take cartilage with it. You can take based on the descending genicular artery, superior medial genicular artery, or you can descending genicular artery, and you can take bone from here, or you can take a small piece of cartilage to reconstruct the proximal pole. And these are from Dr. Berger, and non-union of the proximal pole excised, the vessel taken along with the cartilage, and this is fixed there. And subsequent arthroscopy shows that the patient had good reconstruction of the joint, and patient has good clinical result. And X-rays and MRI shows good reconstruction. So the vascularized bone graft is a useful adjunct for complex scaphoid non-union. It's important to understand the detailed anatomy of the sources that you're going to take, and stable fixation of scaphoid non-union is still necessary, even if vascular bone graft is used. So what's new? New thing is the scaphoid plate that provides stability. This is from Scott Edwards from Phoenix, and this is our case where we've taken the bone graft from the volar side of the scaphoid and put in a graft. We're doing a series on this. What are the salvage procedures if these things don't work? Well, it's bends on through operation. You can excise the distal pole of the scaphoid. It will buy the patient about 10 years before you have to do something else. You can do radial styloidectomy. You can do denervation. You can do snack procedures, that is excision of the scaphoid and four-corner fusion, proximal row carpectomy, limited carpal fusions, complete wrist orthodesis, or total wrist replacement. So you don't want to end up like this, where the patient has a four-corner fusion or proximal row carpectomy or wrist orthodesis. But the most important point of this lecture will be that for scaphoid fractures and non-unions, we need stability, and we need stability for good outcomes. So the contents of this and others will be published in a book, hopefully next year, with my good friends, Dr. Mudgal, Dr. Randy Bindra, and Joe Dias from Britain. So thank you very much. Thanks for the opportunity of presenting this. I hope you enjoyed it. Thank you.
Dr. Gupta, thank you so much for an outstanding presentation and a whirlwind review of all things scaphoid. I know that Dr. Shoji and Dr. Rizzo have some questions from the participants, and I'm going to give them an opportunity to do so. I want to just touch base on something that you discussed within the beginning of your talk about the unreliability of determining fracture healing and by plain film alone. So obviously, there's a clinical aspect of it with patient-reported symptoms, tenderness, and those type of things. But are you routinely recommending advanced imaging to determine scaphoid healing before you clear patients to go back to various activities, or are you basing your decision on what the X-rays look like, what the patient tells you?
Yeah, I base my decision on clinical, as you have said, and also on sequential X-rays. So I do sequential. If there's any doubt, I do sequential X-rays. And if there's any doubt on that, I would do a CT scan. The CT scan is a gold standard to show me that if the fracture has healed or not. And if the fracture is healed 50%, I let them go.
What do you do in a situation of a patient who has no pain, great range of motion, but at 3, 4, 5 months, the fracture line is still visible, and maybe this is a stable pseudarthrosis. The screw's not loose. What do you do in that situation? I
just follow them closely and hope for the best. Generally, if you stably fix them, they will heal. But if that kind of situation does happen, and what you do is you follow them closely, and if the patient is asymptomatic, obviously there's no indication of doing anything. But if the screw loosens out or the patient starts getting symptoms, then I would offer them another procedure.
Very good. Monica, Marco, you have any questions from our participants for Dr. Gupta?
Go ahead, Monica. I think you had, I was reading through the Q&A. You were going to ask a question for Dr. Gupta.
Yes, thank you. One of the participants wanted to ask about, in the case of failures of conservative treatment that present with severe dystrophy, which I think we're talking about maybe like a dysvascular region of the scaphoid, sort of what's your approach to that? And I think maybe if you could stratify it based on location and maybe your algorithm for what type of vascularized bone graft you're considering and when.
Okay, so if the patient has, failure of treatment, the patient had surgery and now got dysvascular scaphoid, sometimes what happens is that patients had surgery, 2 or 3 operations, and then there is not only dysvascular changes of the proximal pole, but there could be some dysvascular changes of the distal pole also, and I've seen that. And in those cases are challenging. So in those situations, I would definitely use a vascularized bone graft. What I do is I use mostly, because in most of these instances, there is collapse of the scaphoid, so you have to reconstruct the scaphoid. And I prefer to use the volar Malone graft, which is taking the palmar carpal artery graft and take a large section of that and then pack it in there. Sometimes you may have to take some Cancellous graft from the crest and then do a composite type of a graft, back that. But generally, I find that a palmocarpal graft will suffice, and I'm putting a plate on top of that to stabilize it further, okay? Because what will happen is you have to take out the screw. There's a big hole in the scaphoid now, and you have to pack that with some cancellous bone graft and then stabilize it. You can't put another screw in, so I'm using the plate. I'm very happy with the plate so far.
Great, thank you.
Amit, thank you so much for your wisdom. It's amazing. What an experience. A couple thoughts in line with the plate. What kind of tips could you give us in terms of how to put the plate in the right position to avoid impingement, avoid plate-related or hardware-related issues?
Right. The impingement is a big problem because obviously there's not a lot of space to put that plate in. So the thing to do, first thing is, the plate, when you put it in, it's counterintuitive. You think it's going to go one way, but you flip it over and it goes in the opposite direction. You have to make sure that you're putting the plate in the right way. Okay. And then the next thing is putting these locked screws and try to get them separated out and going into the distal and the proximal pole. And make sure if you're using a vascular bone graft along with it, that the pedicle doesn't get caught up in that in the plate. So try to plan the procedure so that it doesn't get caught up. If you're using non-vascular bone graft, cancellous bone graft, that's not an issue.
Wonderful, Amit. Thank you. I don't know how much more time we have, Kevin. I don't want to eat up into too much, but there's several other questions that I would love to run by Dr. Gupta.
Yeah, I think our chairman has said we could go to 8:30 if we needed to.
Okay, wonderful. Thanks, Jai. In line with the fixation theme, I mean, how do you decide? I saw the one photo with two screws. One of the questions from an attendee was, how do you decide one versus two screws? Talk us through your algorithm. Is it based on the fixation of one screw at the time, or
it is just the question of happiness? You can put one screw and you can make it really look good. I can get a good X-ray, but only I know how good and stable that fixation is. So I have to know by feeling the screw. And I was not happy. When I'm not happy with that, I would either put a derotation K-wire or another screw to stabilize it. It's hard enough to get one screw in the right place. It's very hard to get two screws, I can tell you. But two screws do give good stability.
And I saw in your case you did a 3-5 and a 2-5 screw.
Yeah.
Okay. What do you do? One of the questions that was from one of the attendees, and I answered a response, and I wanted to get your experience since you've seen so many. If there's a concomitant SL injury, which is very rare, I think, but if there is, do you repair it at the time of fixation?
No, I'm not. I would just, many times the scapholunate gap, I mean, if you look at some of the studies that have come out from Norway and Sweden, they've shown that if you do an arthroscopy, you'll see a large proportion of these scapholunate gaps and scapholunate injuries. They're not going to be necessarily going on to clinical scapholunate separation. There may be some widening, which generally can settle down, but I would treat the scaphoid and then deal with the scapholunate problems if there's any. And I haven't seen that. The scaphoid fracture just heals up pretty good.
Okay, thank you. Monica, if you have any additional questions, feel free to chime in. I can keep going. So let's talk about the healing. We just talked about the case, Kevin, and you discussed with, 3 months out, there's still fracture line. Is there a role for ultrasound stimulation, non-invasive electrical stimulation to promote healing? What are your thoughts on that?
If you look at the literature, there are some papers which would support that and support ultrasound and electrical stimulation, etc. I haven't found a great use for that. I think stability is the key for me in the scaphoids. Stability. If you can stabilize a scaphoid fracture, it will heal. Why it's not healing? Because it's not stable. The screw may not loosen for a while, but eventually the screw will loosen and the patient will get symptomatic. but the stability is the key factor for this, and I don't put much reliance on these stimulations.
Wonderful, Amit. Thank you. We have a wonderful group of faculty that are listening in. Any questions from the faculty? I see Dr. Hastings is on the line, and I'm sure he has.
Dr. Hastings, our teacher.
I know he's our educator. I see Emil, Kim, Lauren.
Yeah, actually, I would like to ask a question, Dr. Gupta.
Yeah.
Back to the your assessment of healing kind of protocol. Do you feel or do you believe that a CT scan is usually required to confirm the healing, or if the patient clinically is doing well and the clinical exam is positive, would you still feel that a CT should be done? Is that maybe
that's not no. The CT scan is the gold standard for healing. Okay, but CT scan is not that I use every time. I would go with clinical presentation. I would go with serial X-rays. Okay, in different planes, and if there is any doubt, I would get a CT scan. So CT scan is the gold standard, but not that I use it all the time. My point was that at 12 weeks with X-ray, you can tell. Just 12-week X-rays, you cannot tell whether the fracture has healed or not.
So if you had an X-ray that was suspicious or a clinical exam that wasn't perfect, either one of those or both would trigger your.
Yes, I would then bring the patient back next month, and I would re-examine, re-X-ray them. I'll bring the patient back again another month, and then I would in the meantime mobilize the wrist, and then if there's still any doubt, I would do a CT scan.
Thank you.
Thank you, Amit. I think we're going to, Emil, I see you there. You're off mute. You're about to say something. I feel it.
Yes, so I have a quick question with Dr. Gupta. When you go in the volar vascular grafting, which I've done a couple of times with good result, but I have problem to what to do with the volar ligaments. The volar radiocarpal ligament, which I think is an important ligament, but that vascular graft is right over that ligament. So you end up cutting them all or somehow going around it.
What I do is I put a needle just to make sure where the joint is. And then what I do is I go just proximal to the ligaments, and I'll direct my the saw slightly volar and proximal. And that way, when you do that, you avoid the ligaments. So I avoid the ligaments.
Sure, yeah. You avoid the ligaments for harvesting, but when you rotate this thing to put it in the scaphoid, the radioscaphoid ligament is right where you want to put it.
Oh, and the radioscaphoid ligament is gone, and by that time, the radioscaphoid ligament is cut. As Dr. Carter taught me, I cut through that puppy.
Okay, so that helps.
That helps, yes.
Do you take the artery too, or do you try to preserve it? There's that branch of the artery, the radial artery that comes across.
The radial artery. I try to preserve it. If it's a big artery, I try to preserve it. If it's a very tiny branch, there's a lot of variations of that artery. Yeah. If it's a very tiny branch, I buzz it. Yeah.
Well, Dr. Gupta, thank you so much. It was wonderful. Great day, great education, and a wonderful experience. Thanks so much for sharing.
Thank you. Appreciate it.
Well, thanks very much. And on behalf of the AO North America Hand Education Committee, thank you to all of you who participated tonight. Again, you'll be provided a link to where you can view this presentation again on our YouTube channel. And at the end of this seminar, you'll be given a survey. But again, remember that your CME credits won't be available for you to collect until after the last of this series, which will be 2 weeks from this evening. And you'll receive information on registering for that if you have not already. Thanks again, and have a good night.
Good night. Thanks, Kevin.